a big problem in diabetes, not only in Egypt, but all over the world. And we can see that the armamentarium to treat patients with type 2 diabetes has been a long way, starting from the 1950s when we used the first generation sulfonylurea with metformin, moving to the new generation of sulfonylureas, more a new insulin, and moving to the most recent group of drugs, the DPP-4, the SGLT2 inhibitors, and the GLP-1 receptor agonists treated nowadays. And if you go to the guidelines, you can see the ADA 2021. You can see that the GLP-1 analog has got actually put in the front row for treating patients with type 2 diabetes. Not only for patients with cardiovascular disease, but also with patients with obesity and fear of hypoglycemia. And the same applies for the SGLT2 inhibitors. They are still in the front row for treating patients with type 2 diabetes. And if you go to Diabetes Canada last year, although they have put metformin lifestyle as usual as the first treatment, but again, GLP-1, SGLT2 are still in the front row. And they have put sulfonylurea, I can see, in a red house or box just at the bottom of their guidelines. So this let me ask myself this question. Is really a role for sulfonylureas in 2021 or maybe 2022? Yes or no? So these are my disclosures. And in the next 17 minutes, what I'm going to do is just try to explore how can sulfonylureas compete with the powerful SGLT2 inhibitors, GLP-1 analog. Powerful because they've got a lot of trials, a lot of data, very evident data of cardio-renal protection. So maybe at the end, I will be able to convince you that there is still a role for sulfonylureas in 2021. I'm going to play the role of a lawyer in front of a court and defend my case following 6 points. So the international guidelines, the frequency of uses of SUs, efficacy, risk of hypoglycemia, weight gain, and cardiovascular safety. Let me start with the first point in my defense. Is the international guidelines. You have heard that the International Diabetes Federation guidelines, the last 2017, they put sulfonylurea in the front row after metformin, and also in addition to the DPP-4 inhibitor and the carbose. And as a combination, again, there is still a role for the primary care physician to use sulfonylurea after metformin. So still they are put in the front row. For the NICE guidelines in UK, you can see that patient with symptomatic hypoglycemia, still insulin and sulfonylureas. And of course, you have to start with metformin if the hemoglobin A1C is above 6.5. And for if you want to intensify, you can add sulfonylurea in addition to other agents, but still there is a role for sulfonylurea for NICE guidelines, and even for triple combination, still SUs are there. And for the WHO, actually, WHO recommended that give a sulfonylurea to a patient with type 2 diabetes who do not achieve glycemic control with metformin alone. So this is very evident and clear. And they have stressed the fact that for the newer agent, the sulfonylureas, new generation, glimepiride and gliclazide, have been useful in this context. But again, I'll go back to the ADA, and you can see the ADA guidelines. Still, they have put sulfonylureas still in the yellow arrows. So there is still a role, even for the ADA, for the sulfonylureas. The second case is the frequency of uses. I'm going to further this publication. I was lucky to use Professor Samir Naim Asad Khalil and another group of experts from the Middle East. And we did show indeed that in Egypt, the most common agent after metformin was sulfonylureas. And look at that, not only in Egypt, but also in wealthy Middle East country like United Arab Emirates. And you can see there's still sulfonylureas are there. So it's not a matter of cost, it's not a matter matter of the relevant countries, yes or no. And if you move to the UK, you can see still sulfonylureas are being recommended as a second line of therapy, particularly stressing on glimepiride and glycoside MR. And if you go to the USA, this is a very interesting study on more than 1 million patients from the EHR, the electronic health records, and you can see in these bars, the blue one is sulfonylurea. So still, starting from 205 to 217, still sulfonylureas are being used in the USA. The third point is the efficacy and complication prevention. And you can see that efficacy is how drug performs under condition of clinical trials. And unfortunately, there are no very good clinical trials for especially cardiovascular trial for SUs. I will show you some. But effectiveness, you can see the effectiveness in our clinical life. So effectiveness is how the SSU are used and powerful. And I'm going to refer to the very small study comparing SU, this is glimepiride, versus DPP-4 inhibitor. And you can see with glimepiride, there is a definite more powerful effect in reducing blood sugar. And I'm going to refer to the great study published this year, presented at the ADA. And this was not funded by any pharmaceutical company. It was funded by the National Institute of Diabetes, Digestive and Kidney Disease USA. And they included about 5,000 patients with type 2 diabetes of different duration. And they have divided this patient after metformin to patient receiving metformin plus GLP-1, metformin plus insulin, basal insulin, metformin plus sitagliptin, sorry, and metformin plus sulfonylurea. Here it was glimepiride. So we've got 4 arms: GLP-1, DPP-4 inhibitor, SITA, sulfonylurea, and again, the last group did not include, of course, the SGLT2 because they were not there at that time. And you can see that the response is more or less similar, although there was a little bit of statistical effectiveness of glargine and liraglutide. But look at the glimepiride arm, 72%, or you can take it 28%, they achieved a goal of less than 7. So it's more or less similar to the liraglutide arm and the glargine arm. So really sulfonylureas are effective. And you know that diabetes is still the disease of sugar. You cannot diagnose diabetes except by high hemoglobin A1C. So still you have to control the blood glucose. And indeed in the UK prospective study, reduction of hemoglobin A1C 1%, there was a huge 37% reduction in microvascular disease, while MI, it was quite modest. And even in the other trials, the ACCORD, advanced, VADIT studies, they did show that reduction of blood sugar is very important for the microvascular. So you don't have to forget the microvascular, please. And in the advanced study on glycoside, they did show, apart from efficacy in controlling blood sugar, there was a reduction in the new worsening of nephropathy and macroalbuminuria. I'm going to allude to this very interesting study. This was from USA again. It was a study on 37,000 patients, again, by electronic health record. And they divided the patient in taking metformin plus any other agent. So T1 was metformin plus sulfonylurea. T2 was metformin plus DTP4. This is metformin plus GLP-1, and T4 was metformin alone in addition to insulin. And look at the data in both women and men. The mean time to use insulin was quite longer patient with sulfonylurea. So it seems that the early use of sulfonylurea does not lead you to more insulin, as we usually think and usually tell our students or tell maybe our patients. So it does not exhaust the pancreas. And indeed, this is an old study. This was in vitro study that glimepiride, even the old clopramamide, the cheap one, did not increase the apoptosis of the islet cells. So actually, sulfonylureas are not exhausting the pancreas as we usually say. The fourth case is the risk of hypoglycemia, and you know that sulfonylureas have been there for hypoglycemia. The risk is evident. But this is not with the new generation. With glimepiride and gliclazide, from the South African guidelines, this was evident the risk is much lower. And even in the GRACE study, I've alluded, in which they have used glimepiride, even in comparison to insulin GLP-1, so the rate of hypoglycemia was similar with glimepiride. And in this very interesting study, the steadfast study was an international study, and I was lucky to share in this study done in Cairo and Alexandria, and all over the world as well. This was studying patients with diabetes in Ramadan, in which we compared with the gliptin versus gliclazide. And strange enough, there was no change in the hypoglycemia between gliclazide and vildagliptin. And this is very evident. This was published in 2014. The fifth point is the weight gain. Of course, sulfonylureas have been there, famous with weight gain, but this is not true. Because you can see in this study on the glimepiride, again, this is in orange, the effect of hemoglobin A1C. There was a reduction, effective. But what about the body weight? It did not go up. My last case is the cardiovascular safety of this group. Not only cardiovascular, but even renal safety. And you can see, starting from the UDGP study, this very old, very bad, constructed study in USA, they did show that with sulfonylurea maybe more mortality, but actually this is not the case. Because with glimepiride and gliclazide, the survival is quite good. Of course, it's better than glibenclamide. And in this meta-analysis, on 37,000 patients, they did show that with gliclazide and glimepiride was a lower risk of all-cause mortality compared to gliclazide. So we have to differentiate between the three groups of sulfonylureas. And of course, in the Carolina study, which they compared linagliptin, the DPP-4, versus glimepiride as a sulfonylurea, and again, there was no bad effect of glimepiride as sulfonylurea on the MACE or even on the cardiovascular death. And the cardiorenal protection, the renal effect is very evident here, because in the KDIGO guidelines, although it is old, but still 2020, they put the same. You can use sulfonylurea, particularly the glipizide and the gliclazide, without dose adjustment, and you can use the glimepiride, but starting with a small dose. So still, there is a role for sulfonylurea in renal patients. So at the end, Madam Chair, ladies, Mr. Chairman, dear attendees, in my court, I did not plead guilty for sulfonylureas. Actually, I plead for innocence. Actually, they are innocent because they are a powerful drug. They can reduce the blood sugar. The affordability is with them. Accessibility is with them. Although we cannot ignore that the new drugs like SGLT2 inhibitor and GLP-1 have got a very important role in cardiac and renal protection. But still, sulfonylureas are there. So newer anti-hyperglycemic agent may have cardiovascular and renal benefits, as I mentioned, but clinical importance of glucose lowering shouldn't be overlooked. Second generation sulfonylurea like glimepiride, gliclazide, MR have got a lower risk of hypoglycemia with a lower risk of microvascular, with reduction in the risk of microvascular complication with a more intensive glucose lowering effect. SUs actually have shown to be cardiovascularly safe, the new generations I told you, and can be used in renally impaired patients. You should, as a physician, individualize your treatment, taking into consideration all the different facts, not only the cost, but believe me, we are not using the SAUs because of the low cost, but they are powerful, as I told you, with a lot of good points for them. And again, the use of sulfonylurea in addition to metformin has got a big role in managing patients with diabetes all over the world, not only in developing or poor countries. And thank you very much for your attendance, and we hope to see you in Alexandria, maybe next year for a physical. Actually, we've stopped our activities in Alexandria for a couple of years for the corona, but maybe next year, inshallah, we'll be meeting there too. You can see the old port of Alexandria with a beautiful sunrise. This is a sunrise view, and this is the sun rising from the site of the beautiful new library of Alexandria. And see you next year, inshallah. Thank you very much.
شكرا Professor Samir Naim for your elegant talk. بس